All right, we'll go ahead and get started. My name is Noelle Young. I'm a neonatologist at Duke University in the US. And on behalf of the Tiny Baby Collaborative, I'd like to welcome you to today's webinar. Our topic today is Meconium Obstruction of Prematurity. And our speakers are Dr. Graeme Pitcher, who's a pediatric surgeon at the University of Iowa, and Dr. Simon Kao, a pediatric radiologist at the University of Iowa. Following their talks, we'll hope to have some time for discussion and to hear from our moderators. Joining us, we have Dr. Ravi Patel, who's a neonatologist and necrotizing enterocolitis researcher at Emory University in the US, and Dr. Akio Kubota, a pediatric surgeon from Japan who authored one of the first key papers defining this condition. So if you have questions that come up, please feel free to use the Q&A feature in Teams, and we'll try to address them as time permits. Please save the date for our next webinar. It'll be held March 14th. The topic will be antenatal counseling, and we're excited to have Dr. Marlise Hayward and Dr. Lex Doyle leading that session. As a reminder, all of these webinars are recorded and placed on the Tiny Baby Collaborative website. We're also excited to announce that we'll be holding an in-person meeting at the Pediatric Academic Societies meeting in Toronto. This will be held Friday, May 3rd at 10 a.m. So please keep that time and date in mind as you make travel plans, and look out for further details coming soon. This slide shows the makeup of our audience today. Just over half of participants are neonatologists, but we're excited to have multidisciplinary attendance, including nurses, nurse practitioners, trainees, and others representing over 40 countries. When you registered for the webinar, we asked a couple of survey questions. We asked how many days after birth do you expect until first stool passage in infants born at 22 to 23 weeks gestation. You can see the most common responses we received were between 2 to 5 days, but around 20% answered 6 days or longer. And then second, we asked whether you routinely use interventions to support meconium passage in infants who have delayed stool passage or signs of obstruction at 22 to 23 weeks. And 61% of respondents answered yes. And of the yes responses, the most common first-line intervention was glycerin suppository, followed by glycerin and saline enemas. All right, with that, I'd like to turn it over to Dr. Matt Rishavi, who is chair of the Tiny Baby Collaborative, and he's going to introduce our topic today.
Thank you, Dr. Young. I appreciate the introduction, and I really look forward to today's talk. I just wanted to provide a frame of reference for what we're talking about today. Why talk about bowel pathology in tiny babies? I hope the answer is fairly clear to most of you. Here I show data from pediatrics. This is about 1 in 5 US NICUs, and we show the incidence of SIP, spontaneous intestinal perforation, sometimes called FIP, or focal intestinal perforation, and then medical and surgical necrotizing enterocolitis. And you can see that there have been great improvements over time for babies born at 25 to 27, 28 to 30, and 31 to 33 weeks. But when we look at our population that our webinars focus on, not only do you see that the highest incidence of all of these bowel pathologies takes place in these babies. This is as of 2019, but the incidence appears to be increasing, including here when we cut all bowel pathologies into NEC and SIP in the SIP category. But we know that there's more to bowel pathology than necrotizing enterocolitis and spontaneous intestinal perforations. There's a very nice piece recently written by a pediatric surgeon, Professor Hall, who wrote that while NEC and SIP are most commonly encountered causes of abdominal pathology that may require surgery, they are not the only ones. He lists meconium ileus of prematurity, milk curd obstruction, volvulus with or without malrotation. These may be under-recognized, I think, and they aren't things that we track nearly so systematically as bowel conditions such as NEC and SIP. Some of us may not be familiar with some of the discussion on some of the language that we're going to use today. I think it's very interesting that when we talk about these other conditions, we find ourselves at a loss for standardized terminology. You will find, if you go to PubMed, literature on meconium obstruction of prematurity. That's the term we chose to use for this talk. But also meconium ileus of prematurity, meconium disease in premature infants, microcolon of prematurity, and meconium-related ileus. You'll find dozens of citations on these topics. They tend to be segregated geographically. In certain countries, certain terms are used. But we find ourselves without, I think, a coherent way to describe a phenomenon that many people in many parts of the world have observed. In Japan, the Neonatal Research Network of Japan includes what they describe as meconium-related ileus, MRI, as a three-letter morbidity, the same way you would include NEC, ROP, BPD, etc. I think it's notable to have such a very distinct morbidity category that is not even very commonly recognized in the United States. In the database, and with the data that I'll share with you, which come from Dr. Kasuda, who is generous enough to share with us the last 3 years worth of information that they've collected, MRI is defined as a functional ileus treated with contrast enema or equivalent procedures. This is using a definition by Dr. Kubota, who's on the panel today. So of 9,400 babies before 33 weeks gestation, 172 had what was described as MRI. Some of these babies had focal intestinal perforation or necrotizing enterocolitis diagnosed, and that's something our speakers will talk about today. You can see here how these babies were treated. 16 had missing treatment information. About half had medical treatment only, and the other half had some form of surgical treatment, predominantly laparotomy, oftentimes with an ileostomy, but not always, and occasionally with simple drainage. Here you can see mortality by each of those treatment modalities, and you'll see that about 27% of babies who had a perforation related to MRI that was treated with the laparotomy died. So when we talk about meconium obstruction of prematurity today, I want to be cautious that we don't distinguish this as a very perfectly characterized disease entity. We all know that this may be foreign in many of our sites. This is something that many of us, it's not part of the neonatology canon, for example, in the US. But I would like to end on the note that I think it's good for us to be cognizant of what others are talking about and to learn from the experiences that are taking place in some isolated centers and sometimes in entire countries, like with the Japanese neonatal network. I find useful the analogy to diabetes. For much of the 20th century, diabetes was classified on an epidemiologic basis, such as juvenile onset, or by diagnosis of severity, latent, subclinical, overt, maybe similar to how we talk about bowel perforations now, where SIP and NEC are sometimes distinguished by epidemiologic characteristics, and sometimes we categorize NEC in terms of, for example, the Bell classification by severity. But by understanding the etiologies, by distinguishing type 1 and type 2 diabetes, I think we've made great strides in prevention, prognosis, and treatment. So while I think we should come with humility and some uncertainty about some of the discussion today, I hope that the discussion fosters new thinking. To quote Thomas Kuhn's work, or to cite his ideas, paradigms, the ideas of what we call a disease, for example, are things that a scientific community shares. And the way that these develop often occurs in small networks of scientists. I have personally benefited from listening to some of my colleagues in Japan, in Sweden, in Germany, the original collaborators here in the Tiny Baby Network. They've really helped me better understand bowel pathology in the tiny babies I treat. And I think by allowing our thinking to unfreeze a little bit, to allow some new ideas to fly around in the group until something that seems like a good model that works. This should be the goal of our webinars, and I hope that the conversations today spur some new thinking and give some new perspective in your own work. Thank you.
Hi. Thank you, Dr. Rashevi. Hi, I'm Graeme Pitcher. Thank you for the opportunity to speak. It's marvelous that the technology permits us to have this truly international collaboration. And I'm going to speak on meconium obstruction of prematurity from a surgical perspective primarily, but also address some of the medical management. And I have no conflicts of interest. My slide will not advance for some reason. There we go. So I'm going to present our experience with this condition over a 13-year period. I'm going to discuss why we feel at the University of Iowa that this is an independent entity that involves meconium obstructions or abnormalities in meconium. Look at the therapeutic interventions we've used to address this and describe the evolution of our surgical approach and present to you outcomes and mortality rates. So as Dr. Rashevi said, this is a problem really of definitions and semantics internationally. I think we all understand what necrotizing enterocolitis is. It's universally understood, and we have clear patterns of recognition and practice to manage it. But this miscellany of terms that includes spontaneous intestinal perforation, focal intestinal perforation, are used very differently in different parts of the world. In North America, primarily the literature refers to spontaneous intestinal perforation. But in Britain, for instance, the term focal intestinal perforation is used more common. And in the East, meconium-related ileus seems to be the primary term, with a scattering of publications that reflect these other nomenclatures. And quite frankly, this is an enormous obstruction to making progress. If we can't universally define, understand a condition, then we're not going to make progress with it. So I think this is a matter of some urgency. The definition that we've used here at the University of Iowa is meconium obstruction of prematurity, and it's an open lumen obstruction caused by the copious, tenacious meconium that occurs in low birth weight premature babies, typically but not exclusively those of less than 1,000 grams or 26 weeks of gestation. The usual onset is at the time of postnatal intestinal function, with or without exposure to enteral nutrients, usually in the first 10 days of life. And this is important. I think it's a spectrum of disease from a brief self-limiting obstruction to a complicated surgical form of the disease. So in its complete form, it's a medical and a surgical disease, pretty similar to necrotizing enterocolitis. Typically, it has an absent inflammatory response unless this condition progresses to perforation and complications. And it may look like cystic fibrosis, but this is not cystic fibrosis. Over a period of time from 2011 to 2020, we identified 53 cases that came to surgical consultation. This was by a retrospective chart analysis from 2011 to 2020. And then from that period on, these cases were prospectively collected and identified. And if you look at these are cases that came directly to the surgeon's attention. I think Dr. Kao has an additional number of cases that he's going to present that are not part of this cohort that perhaps we as surgeons were never involved with. But these were 53 cases that came to surgical attention over that time. And I've divided them into three cohorts: those that were surgically treated, those that responded to medical and radiologic treatments, and the one single baby who it was elected to provide comfort care only to, for a total of 53 cases. Interestingly, the surgical treatment group had a mean gestational age of 25 weeks. They had a mean birth weight of 678 grams. And overall, our mortality in the management of that group was 9 out of the 37 babies succumbed, for a mortality rate of 24%. The mean day of life that perforation occurred in this group was 10, with the median day of life of perforation occurring at 7.5 days. The medical cohort group, interestingly enough, was a little larger, a little more mature from a gestational age perspective. And of the 15 babies that we as surgeons were aware of, there was no mortality in this group. The one infant who was a 22-weeker born at 500 grams with multiple comorbidities, who was provided with comfort care, obviously succumbed. If you look at the distribution over the years of study, there's a kind of steady smattering of these cases over time. And we've looked at these patients as part of a previous cohort, and I'm going to briefly go through this because I don't want to waste all of your time. But essentially, babies with, at that time we were calling it the inspissation of meconium of the premature infant. These babies were compared to a group of controls in this right side, and then compared to that condition, what was thought to be SIP and what was thought to be NEC or perforated NEC. And you can see that the perforated NEC and the NEC patients are larger than the group who have meconium disease. Interestingly enough, the APGARs were the lowest in the patients who were deemed to have spontaneous intestinal perforation. If one looks at the cohort with meconium disease, again, it's a little confusing because we're using a different nomenclature, but just for correctness, that's the name we called it at that time. You can see that these babies were slow to start feeds. They reached 40 mils per kilo on an average much, much later compared to patients who developed, who had no signs of obstruction. They had a much lesser volume of ventral intake, and they had slower stooling. In addition, these babies were exposed to hydrocortisone postnatally more frequently, and they had requirement for presses more frequently than their cohort of controls. So of the patients that were explored by laparotomy, there were 36. I'm going to show you what we did surgically. One patient was treated by drain alone and never came to subsequent laparotomy, and ultimately succumbed from sepsis. So our results in this institution in terms of draining alone have been pretty poor, and the single patient that we tried it on did not survive. The vast majority of our patients were exposed to laparotomy and underwent a resection and a proximal stoma. A single patient had a primary anastomosis. A single patient had a distal oversow with a proximal stoma. One patient had a washout alone where a perforation could not be identified. And one patient had a kind of milking of the intestine alone where obstruction was treated, but there was no sign of perforation at the time of surgery. In one individual, a patient became unstable intraoperatively, and the surgery was attenuated to a damage control type of procedure. 17 of the patients had a drain prior to laparotomy. If you look at the way that drainage was performed, in 5 patients, the drain was deemed to be resuscitative. In other words, it was placed to stabilize the baby with a view to taking the baby within a short period of time, defined in this study as less than 2 days, to the operating room. And the remainder of the patients who had a drain prior to laparotomy, the drain was there for a longer period of time. Interestingly, so this is the typical baby, and I've included these photographs because some folk may not be familiar with this condition, and it presents phenotypically, very typically, you have this bluish or greenish discoloration of the abdomen in this very specific configuration. Often the radiology is fairly benign looking, or there's a paucity of gas, but this is the appearance that in the very early days of our study, we failed to detect perforation in some of these babies in the first day, for instance, that it occurred. And an infant like this who is compromised will get a drain in the standard fashion with a Penrose tube in the right lower quadrant. When we looked at our outcomes, and this became apparent fairly early in our experience, that a standard drainage approach was resulting in high incidences of sepsis that are really difficult to manage in this fragile group of very premature neonates. And so when we look overall at the patient survival by surgical strategy, there are 6 plus 13. There are 19 patients in this first category. The patients who had a drain alone, or the drain was used as a definitive treatment with laparotomy as salvage, in other words, a long duration between the placement of the drain and the final laparotomy, had a 46% mortality rate. And as a result of this experience, we moved to a more aggressive surgical approach. And the latter part of the cohort, where we used a drain only in patients who need it from a resuscitative perspective. So there are 5 patients who received a resuscitative drain in this category. And the remainder of these patients received surgery up front. The mortality rate was much, much better. So a little counterintuitively, we found that a more aggressive surgical strategy resulted in better outcomes. Briefly, we do the laparotomy at the bedside. There's anesthesia and NICU faculty. We use the standard isolation and thermal precautions. We make a tiny little minimal transverse umbilical incision. Importantly, there must be no instrument handling of the intestine. The disease is typically limited, and we perform a minimal resection of bowel. We exteriorize proximal to the perforation, create a stoma in the actual incision, if possible, and then we attempt to close the patient's abdomen if that's at all possible. I'm including this slide because I think it's really important. This is a patient in whom I picked up the intestine with a DeBakey forceps very, very gently, and there was an immediate contusion in the wall of the small intestine. And these cases taught us that one cannot handle this intestine with instruments. This is in conflict with the existing literature. This is the first paper that came out from the group in Texas, indicating that peritoneal drainage is probably the preferred way of treating babies with what is thought to be isolated intestinal perforation, or SIP. And this group's experience kind of indicated that this category of baby is ideally treated by drainage alone. And that's what really led us to our initial operative strategy. The NEST study also indicated that there seems to be, and this is really elegant Bayesian predictive statistics, that in the NEC group, there is a potential treatment benefit for early laparotomy in terms of neurological deficit or mortality. But then patients identified as having intestinal perforation that's spontaneous, or SIP, that the potential treatment benefit of laparotomy is likely to be less. And this was not what we found in our clinical practice. So this has been the genesis of our evolution in Iowa. On the second day of life, if the baby has not had any spontaneous stooling or smear, the baby is given BID glycerin suppositories. If by the third day there's still no spontaneous stooling more, that's greater than a smear, then they progress to TID glycerin suppositories. And if by the 5th day of life, there's still no reasonable stooling, and a contrast enema is performed in the radiology suite. The feeding strategy is at the discretion of the neonatologist, and feeds are not typically withheld unless the baby is frankly obstructed. And I'll give you some examples. I know that Dr. Kao is going to go into this in more detail, but it's really dramatic. Here's a recent baby of about 600 grams who was profoundly obstructed, who underwent a distal contrast study on the 4th day of life, and had a dramatic improvement. So in many instances, we found this to be beneficial from a therapeutic perspective. This is an interesting case that I cite because this is a baby that developed an unhappy abdomen on the 22nd day of life, had this rather strange X-ray that showed this bubble, which was thought to be extraluminal, and was subsequently confirmed on a distal contrast study that there was a perforation from the terminal ileum. And when we operated on the baby at 22 days even, we found this enormously inspissated meconium with a perforation in the terminal ileum. And you can see in this area in the subhepatic space, this isolated and sequestered perforation of meconium. So, our clinical exposures seems to show us without any doubt that meconium disease is the cause of this in many instances. I don't say in every instance, but in many of these babies. I've included all these gory photographs because neonatologists don't go to the operating room that much. But here's an example of the distal intestine in one of our babies impacted with a cast of solid meconium. And so that's sometimes, the appearance that we see. Here's another example. And our findings are a little different to what our Japanese colleagues and Dr. Kubota has described. He has found that the perforation tends to occur distal to the transition change in the intestine. In our experience, the transition change is where the perforation occurs. And in many instances, you can see here's a limited area of intestinal ischemia. The intestine that is upstream from the perforation discharges all the meconium into the peritoneal cavity, and there's a discrete color change between the intestine upstream and downstream from the perforation. This is what I deem to be spontaneous intestinal perforation, a patient that has a usually anti-mesenteric limited perforation on the anti-mesenteric side of the bowel without an abnormality in the distribution of meconium around it. So I think it's really an important semantic distinction. Spontaneous in the dictionary is referred to in medical terms as developing or occurring without apparent external influence, force, or cause. So in other words, natural. And if one does a PubMed search, there are 91,000 PubMed articles, including the term spontaneous in the title, which makes me a little suspicious that we sometimes don't understand the etiology. The first use of the term spontaneous is used in the Glasgow Medical Journal of November 1929, which described spontaneous perforation of the stomach in a patient with a clear gastric ulcer that had perforated on a peptic cause. So the first use of spontaneous was an indication of the failure to understand the pathology at that time. And the first use of spontaneous intestinal perforation came from Edinburgh in 1961 by this gentleman who described a miscellany of causes of intestinal perforation that included necrotizing enterocolitis and other surgical conditions that we now know have a discrete etiology. And then this culminated in the use of the term spontaneous to describe this perforation from this group out of Michigan, who described spontaneous focal gastrointestinal perforation in this very low birth weight category infants. And this terminology has really stuck in the literature subsequently. From a medical perspective, the risk factors and the etiology, the researchers focused on the antenatal and the postnatal parameters. And I think it's really important to see that increasing gestational age prematurity is probably one of the strongest factors that make these infants at risk of disease and perforation, in addition to the use of antenatal steroids, magnesium, and indomethacin. Postnatally, these risk factors have been addressed, and it appears, as we found in our study, that postnatal hydrocortisone, indomethacin, and vasopressors are associated to some extent with the risk of this disease. Interestingly, a number of people have looked at dehydration with a proxy of maximum weight loss as a risk factor. And it does appear that as infants being managed with prematurity become drier, their risk of perforation increases. So we believe that the meconium plays an intrinsically important role in the etiology of this disease, that the severity of prematurity is an intrinsically important factor. And, I think that there's very limited data on how the 22 weekers exocrine pancreas functions. We know that the full panoply of enzymes do not become active until even in normal post-term gestational life. Urgent research, I think, is needed on the exocrine function of these neonates when they're exposed to luminal nutrient. Dehydration it seems to be a factor. Magnesium sulfate exposure is a factor, and there are these postnatal factors. But I think that none of these things, although true, preclude the involvement of meconium obstruction as a etiology. And I think we really behoove it to our patients to investigate this further, because at worst, if the meconium does play an important etiologic role, we're wrong in our current therapies if we don't treat patients aggressively. And I think that it's an enormous missed opportunity. So in conclusion, I presenting a condition of growing importance as we support more of these tiny infants. There's an urgent need for a internationally uniform form of classification so we can study these patients, research them, and be speaking the same language. It's very akin to the language that was used for vascular malformations, where everything had a kind of food description, salmon spots, and prior to the elucidation of a proper classification system. So I think we need to classify these babies in a universally agreed way internationally. And I think that a meconium abnormality of some form plays a role in an obstructive phenomenon, which it needs to be addressed, and that interventions to ameliorate obstruction are therefore indicated and beneficial. The surprising part of our evolution of our approach is that a more aggressive surgical approach with a primary laparotomy and a drain used only in a resuscitated capacity has resulted in much better outcomes for our patients. And thank you for the opportunity.
All right, great. Thanks for that great talk. One quick question as we're switching over, I see in the chat is for the patients who do have the drain for a longer period, what was the indication for proceeding with laparotomy in the initial cohort?
We used the standard criteria that we used for babies with necrotizing enterocolitis. So progression of sepsis, progression of abdominal signs of inflammation, inability to effectively drain the peritoneal cavity. In some babies, the meconium was too thick and viscous, and we didn't feel the drainage was occurring, and persistent pneumoperitoneum, and then medical deteriorations, instability of these infants from a general perspective. So those kind of standard approaches to declaring drainage a failure.
Great. Okay, thank you. Now we'll hear from Dr. Simon Kao from the pediatric radiologist perspective. Dr. Kao, you just need to unmute yourself.
See my screen now?
Yes, we can hear you now, and we can see your screen.
Is it a proper screen?
I just switched the view again. There we go. It looks proper now.
Okay. So I don't have any disclosure. So with a nice introduction by Dr. Graeme, I'm going to shorten the definition, but I prefer the title Meconium obstruction in a very low birth weight neonates, because, like some of the terms that was used, like meconium obstruction related ileus, or in short MRI, is confused with my MRI means magnetic resonance imaging. So I prefer to use this to be more explanatory, self-explanatory. So this is considered to be a functional obstruction due to highly viscous meconium and poor motility of the premature baby's gut. And some of the guidelines that people, Korean group has outlined is usually they are premature with low birth weight or both, and at least one risk factor, like what Dr. Grant had just mentioned. And usually it's a low-grade bowel obstruction unless you don't treat, and in many cases are actually low-grade without progression to perforation. And in general, clinically, they're usually relatively benign abdominal examination until it got perforated. Then, of course, it's quite different. That we see the discolored abdomen. And then many times we see the characteristic finding is it's a standard loop without airflow level. And this seems to be hold pretty true from most of the images that I will be showing you, because a patient with obstruction in general, if you do a decúbitous view, you will see multiple airflow levels. And this is probably the first paper published in 1979 in Radiology Journal of 3 case report of a meconium blockage in the premature baby. And that's probably one of the earliest paper that was talking about and can simulate necrotizing enterocolitis. In fact, they thought there's necrotizing enterocolitis and operator found that it's all plugged with meconium and there's no evidence of NEC. And since the 20 years ago, the ultrasound has also been used apart from for doing the gastrographic enema, which I'll describe a little bit further. But ultrasound is playing more, I think will play a more important role in the future as well. I'm really humbled by reading all this literature for the last 20 years on this topic. And now we are hopefully we'll be getting more excited to use this modality. This is an example of the, this from the paper of the bladder here and the rectum filled with meconium with these fine echoes. And then if you give the gastrographin, you will form the liquid around the meconium. And as you can see, similarly on the X-ray, you have the meconium as a filling defect, and then the contrast is surrounding the meconium. And hopefully by giving more all the way to the terminal ileum, it will help the evacuation and prevent the surgical stage. This is an example again of the meconium like this. Initially meconium without the contrast. And this is a nice example showing that after patient has gastrographic enema, but after the enema did not improve on ultrasound, repeat ultrasound. And this was found to be due to ileostenosis at operation. So I think we have to keep that in mind. If there is not responsive to your treatment, there may be other underlying etiology. And this is another example of the similar finding, give you different views of the meconium surrounded by contrast that was given during the therapy. The ultrasound can also be used to diagnose perforation during the procedure, which hopefully is not happening, but this is ultrasound of the meconium, and then after a while, suddenly there's appearance of ascites, and on the contrast study showed spillage of the contrast into the peritoneal cavity. So ultrasound can be very useful. And this is an example of meconium, and did not improve after the contrast go into the terminal ileum, and this was found to have more meconium that is not at operation, that is full meconium that need to the surgical operation to remove the meconium. So again, typically clinically there's decreased frequency of defecation, abdominal distension. These are the most common presentation. When I reviewed the chart of the about 30 cases I was personally involved, abdominal distension and then non-bilious or bilious vomiting. On X-ray, you will see small bowel loops, enlargement without airflow level, as I mentioned, but there's also no pneumatosis or free perforation unless it's perforated. The colon could be small, could be normal size, and then you will see multiple filling defect, either in the colon or small bowel or both. And I'm going to show you this ultrasound technique that the Japanese group tried to use the ultrasound guidance, and they use almost like interception reduction, but within the 50 cm height, not 100 cm. And you can use the ultrasound to follow the contrast as you are doing the enema for diagnosis or for therapeutic purpose. The aim is to move this meconium and then fill with liquid, loosening the meconium from the wall, just like this picture is showing. So hopefully the contrast will go into the terminal ileum and will loosen the meconium and get evacuated eventually. So this is probably the most important table that I got this from this article, Journal Neonatal Surgery in 2021, that described the clinical, radiologic, and operative findings. I won't go into detail, but you can look at it later. Since 3 to 4 years ago, University of Iowa started this program, and these are for enema done on patients who cannot be transported to the radiology suite, and we select those patients that are less than 1,000 grams or less than 28 days, and too unstable to come down to radiology for the regular enema. And we have a certain guideline how to prepare for the patient. We also even get consent from the parents. And the procedure, I will not go in detail. You can read it in the future on the handout. I'm going to share with you several cases in the limited time. And so this is a patient who is born at the 28th week, 1,000 grams, no stooling for 6 days since birth, progressive abdominal distension. He also had multiple congenital anomalies. An ultrasound was done on day 5, and then an enema was done on day 6. And you can see there's a distension, distended loops of bowel, some liver calcification. That's part of the congenital anomalies. And on ultrasound, we saw meconium. Nice meconium here. You can see the rectum. This is a longitudinal section with bladder in front, rectum behind. You can see the cast of meconium distended the rectum. And we did an enema. And you can see the filling defect, large filling defect from rectum all the way to sigmoid, to transverse colon, to ascending colon. And we did not reflux because the patient ileocecal valve is too competent. And so we cannot reflux. And you can see the patient's already leaking contrast from the anus, indicating that you probably given enough contrast, trying to reflux into the terminal ileum. But you can see here, the more magnified view, we get up to 40 cc. Of course, 40 cc do not all go into the colon because you can see a significant amount is leaking out despite we hold the cheeks together. And you can see the next day, the contrast all evacuated and patient got better, even there's no reflux. So sometimes it does work, even if you can just fill the colon the best you can. Second case, another smaller baby, 26 weeks, gestation, 528 grams at birth, mild abdominal distension, present with a gastrogastrin enema without fluoroscopy on day 8. And you can see dilated loops of bowel here. Again, despite all these loops, you don't see airflow levels. And then on enema, you can see the reflux, not much meconium in the colon, but then as you go to the ascending colon, you can see multiple filling defects. And we were successfully refluxing into the non-dilated small bowel and not reaching the dilated portion, but eventually, after 2 hours, you can see the contrast percolate into proximally in the dilated bowel. And so this is a successful, this is done on the 12-15. Next day, less contrast out, with some more meconium evacuation, and then one more day, the contrast is all gone and patient is relieved of obstruction. So this is a more typical case, that a successful case. You need to reflux into the terminal ileum and to allow the contrast to go to the dilated portion. The third case, this is a different, the 30-week-old, about 1,000 grams, progressive abdominal distension again. At day 6, enema done. At meconium, can see more dilated than the others. Again, no airflow levels. So this is quite characteristic. No portovenous gas, no pneumatosis. And again, the colon is relatively small, but can be distensible. And not much meconium in the colon, a little bit in the transverse colon, proximal colon. And we are not able to reflux again. So this patient had evacuation, but then got more distended again. And so this patient, we were afraid that there might be some small bowel pathology. So we did try to do a upper GI. And so upper GI showed a nice progression, but slow progression. You can see 9.5 hours, it reached to distal small bowel. And each of these loops are full of meconium that we can't reflux from below. And so this is a few cases that we have done upper GI, and you can see tremendous amount of meconium in the small bowel. And then after 5 days later, you can see the contrast is getting more evacuated and finally clear up all the contrast. And patient was able to tolerate feeding. All the patient I shown earlier, after the enema, patient was able to start some small feed, trophic feed to start, and then more milk and other feeds with progressive more volume. Another patient, 745 gram, abdominal distension, feeding intolerance. Since day 2, we started to do X-ray because of concern about some pathology, and we started to do the day 6. You can see some dilated loops of bowel here, and start to see the meconium, not that much again, but again, you can see reflux into the small bowel, and we got nice meconium at the end of when we removed the catheter. And we can see more reflux after 3 hours, 6 hours, 9 hours, but there's also clearing of the contrast. And it's kind of a little bit static in this ascending colon terminal ileum area, but eventually everything came out and the patient was able to tolerate feeding. So another success story. Now, we also did an upper GI in this case because of the distension persists a little bit. There's no more rotation, and then there are more meconium seen for the upper GI. We clear the contrast all the way, and you can see the contrast eventually reach the rectum, mostly from the small bowel, and all come from the help by the upper GI. I'm going to skip 2 cases ahead because of the timing. And I go to this case. This is a patient who is interesting. Got initially the first day of life, got a perforation of bowel. You can see free air here. And it's very unusual positioning of the esophageal tube. And we were thought that you can see the perforation, free air. And on the contrast, we can see the perforation of the enteric tube through the esophagus, probably. And you can see the contrast in the mediastinum and some air around the lung and heart. And so the patient, this is the 215, and 224, 9 days later, the contrast had gone into this. We saw the meconium. And so we did there's no free air anymore at that time. So we tried to do an enema, despite some residual contrast from the previous study. We start injecting, and the colon is small with meconium throughout. But then with careful examination, we found that there is some extravasation of contrast from the lumen. You can see here, and there's some peritoneal cavity here. And the patient, you can see more leakage here. So this is the only case we have in the 50 cases we have performed. And 30 cases experienced myself. We have not encountered any perforation induced by injection, except this case. We still don't know what the reason for the perforation, but it's interestingly at surgery, there's only 2 millimeter pinhole perforation from the sigmoid colon, which we suspected because it's very distal. And also on top, there's a lot of meconium throughout the jejunum and ileum, which in places the surgeon comment that they are almost about to perforate areas filled with meconium. And so they open up the ileum and wash out the meconium, and so the perforation in sigmoid. On histology, the sigmoid colon perforation is called ischemic, and it's relatively healthy on the gross examination. There's no evidence of necrotitis and colitis. So we assume that this is perforation. Now, whether it's related to the perforation already there but not manifested until we give the contrast, or is already impending perforation in the jejunum from meconium, which we're about to treat. Unfortunately, we did not reflux too much because we saw the perforation very early on as we're doing the study. But we got the meconium from the open ileotomy. Okay, so another patient who has, this is the smallest patient we ever have, 22 weeks gestation at birth, 400 grams. I have done some 300 something grams, but older. But this is a very young patient, a very, very young patient. And on day 12, we did an enema. And since very early on, there's already some line placement radiography. And we look at the radiography, it's not really that distended, but on you can see the relatively gaseous bowel. So this is another pattern. Sometimes we observe if the patient's not fat and you do some little bit low suctioning, you may not see get much. But if the patient is distended, I think ideally this patient should have an ultrasound done to see what's the cause. Is it ascites? Is it content within the bowel fluid or meconium? If there's poor stool output, that's probably meconium. So in this case, we did the enema because of progressive distension. We start with small amount. There's not too much meconium. These are bubbles. But finally, we did reflux into the small bowel. And in this case, I was not confident to see what's going on, and I used ultrasound. And you can see my rectal tube here, and around the contrast surrounding the meconium. The meconium is filling up, and I follow all the way up like the colon course. And then finally, I put the transducer in the right lower quadrant. I found contrast outline a small bowel. So I know that I have enough, and that's correspond to this stage at the time. So this stage, this picture is taken at the same time as this one. So you can obviously, and I don't routinely use the ultrasound for monitoring, but it is fine. I find it very useful. And this is the contrast in the small bowel. There's no ascites to suggest perforation. And after a couple of days, you can see the contrast progressively empty, and patient started feeding and get, and also at the same time, I was able to detect some portovenous gas in the liver, and that's due to a low-lying UVC. How's the timing? Do you want me to stop here?
Yeah, that'd be great. Those are, really, I think, great cases to kind of lead into the discussion. Okay.
Yeah, I'll stop here because there's not much time, and then the cases I include in the handout. Yeah, other cases.
Great. Yeah, and there's a few questions for you as well as for Dr. Pitcher.
Can I stop sharing?
Yep. Go ahead and stop sharing in the chat or in the Q&A if you'd like to address them there. Otherwise, I'll hand it over here to Robbie.
Yeah, thanks, Noel, and thank you to both Graeme and Simon for the excellent talk. Over 460 people joined, so I think this is an important area you've highlighted there. I'll start with Dr. Pitcher, a question around the surgical incision and risk of liver injury in these very, very tiny babies, and whether you use ultrasound to guide kind of the position of the incisions.
Yes, I think that's a really important consideration. One of our babies did have a liver injury. And did poorly. If one gets a liver injury in this situation, it's an almost fatal outcome. So I think avoidance of that is critical. I don't think point of care ultrasound is useful, but entering the abdomen as Dr. Geisler indicated, very, very cautiously, and making the incision as low as possible with a limited incision, I think are the keys. One cannot place a retractor near the liver. One cannot use any metal instrument on the intestine. And so this is a very, very different kind of surgical strategy than even operating on a 28-weeker. So we've evolved, a very specific surgical strategy for these babies.
Another question here from Dr. Geisler on how long to watch? I think you shared the Iowa protocol about 5 days and then perhaps an enema, but at what point, if the baby otherwise clinically is well, or not ill, but unable to be fed, when to move towards an ileostomy when there's no perforation?
That's a really interesting, and I've read all the data that comes out of the East, and the concept of operating preemptively prior to perforation is really prevalent in the writings from that neck of the woods. We have not seen that scenario very commonly. We had one baby in our cohort who was operated on, who did not at the time of laparotomy have perforation. So that would kind of fall into that preemptive group. But we find that babies typically will either get better or perforate. And we haven't frequently been faced with the kind of conundrum that he describes, where you're at day 5 or 6 and you've got ongoing obstruction, your enema has not been successful, and you operate for fear of impending perforation. So it's not something that we've encountered, but I think we're open to operating on that category of patients if necessary. But they're difficult to pick up. These are really tiny infants, and so they're difficult to detect that category of patients in my experience.
Thank you. And a couple of questions here for Dr. Kao. The first is on the choice of the contrast you use. There's a question here on standard gastrographin versus IsoView and any implications, particularly for the smallest preterm infants.
We have been using the gastrographin with this 37% iodine, organic bound iodine, and we diluted 2 parts of saline to 1 part of contrast. So it's quite diluted, about 1/3 of the original osmolarity. We have not had problem, and I think the density, as you can see, that is not too dense to obscure the diagnosis of the meconium. You can see the meconium quite well. And we don't have a problem with it so far.
And a couple of questions, I think you touched on this in your talk about the risk of perforation doing contrast enemas, but particularly at the bedside when when the baby's not able to be transported because they're so ill. Is there a certain frequency of x-rays that you might watch, or maybe you could talk a little bit about minimizing the risk of perforation during enemas in those patients?
So I think is a very careful radiography. I usually start. Let me talk a little bit about the technique. Probably somebody are interested in the questionnaire. So personally, I like to use a 6 French Foley catheter, very soft one, and insert expected depth of the rectum, as you can, obviously a smaller baby, you can't insert too far. And the first picture I took is about, I inject 0.5 to 1 cc. So I can estimate how big is the rectum, how far is the rectal sigmoid junction. I don't like to go beyond the rectal sigmoid junction because I don't want to poke a hole in the junction. So so you can roughly estimate by the first picture you take. And then after that, you give 1 to 3 cc to up to 4 cc every injection, and then take a picture. Sometimes you may need an oblique picture to clarify some corners, and by progressing in that way, and each one, of course, you assess how much is leaked out, and I also very carefully watch the patient abdominal distension. I always like to see how distended the patient is to start with, and because if you add another 15, 20 cc, the abdomen is going to get more distended. So I carefully, even I don't get to the terminal ileum. If I feel that it's too much distension, I usually stop. And as you can see, we try to do this case so we can avoid the surgery. And many of the 55 cases, almost everyone can get to without surgery, except a few cases, either from perforation or from the natural cause, or the patient developed necrotising enterocolitis. Well, I don't have a chance to show one case. The patient developed necrotising enterocolitis 2 weeks after our successful meconium disinfection. And so I don't think it's related to the procedure, but you be aware that always be alert to see any change or unusual happenings.
And coming back to Dr. Pitcher, a question on use of drains. I know you mentioned the preference for laparotomy early on when you're suspecting meconium obstruction. If it's an isolated perforation that's not where there's not a concern for an underlying obstruction, is still the preference in that setting for laparotomy, or is a drain, considering the NEST trial data, a drain a reasonable approach?
I think the surgeon's ability to discriminate neck, SIP, and this meconium obstruction with absolute certainty preoperatively is fair, but not perfect. And so in many cases, when you're dealing with a 22, 23, 24 weeker, the vast majority of perforations in our experience are related to meconium. And although other causes of perforation occur, we had a 22 weeker who's the tiniest baby in your collaborative, who we operated on at 390 grams, who turned out to have necrotizing enterocolitis, surprisingly. And so one can go into it believing that there's one pathology. And Dr. Gordon and Swanson came up with a kind of bedside test to make that distinction, which we agree with and we essentially use. But I think that one doesn't know what you're dealing with until you're in the belly, unfortunately. And so because the overwhelmingly most likely cause of perforation is meconium related in our experience, we tend to apply the aggressive approach to all patients. I'm not confident to stand at the bedside and say this is not likely meconium related. And it's a small isolated perforation that will respond to a drain, because we don't see that very frequently.
Can I add a comment? I would heavily advocate the use of ultrasound for clarifying what the situation. I have cases where there's a free perforation drain, and then and I was in between. I was able to do an ultrasound and suggest that there's perforation meconium in the peritoneal cavity. It was not operated until a few days later. And then there's the more leakage seen in the peritoneal cavity. And that was operated and found a big perforation. So I think if you have an experienced ultrasonographer who know what they're doing and looking at, and it can be an extremely accurate way to, I would heavily advocate that.
I'd like to ask Dr. Kubota if he has any input on that question too. I'd be curious to hear, what you think about when or how to sort of differentiate what's going on when there's these non-specific signs, when to proceed. Can you just unmute yourself, please?
I beg your pardon? Once more.
Sorry, I was asking, how to differentiate infants that have kind of non-specific signs when you're concerned about meconium obstruction and then the initial surgical approach.
In our institute, we always routinely give glycerin enema 6 hours after birth for low birth weight routinely. If meconium is not excluded by glycerin enema, we did gastrographin enema for diagnostic treatment, 3 times diluted gastrographin, to 1, 2 or 3 times a day until meconium is excluded. If no response, we do laparotomy. So for us to diagnose the meconium obstruction or other perforation due to meconium obstruction or neck or SIP is not difficult. So in our institution, we do glycerin enema routinely. And in case of no response, we do diagnostic treatment by gastrographin enema. So we diagnosed MRI very early. So recently, we did not experience any perforation caused by MRI.
The repeated enema should be considered because we have done 2 cases where the initial contrast did not reach the terminal ileum, or even in the ascending colon, it stopped and everything leaked out. So we wait a few days and then repeat again. And next time when I repeat it, I can reflux all the way to the stomach even. So that is the remarkable different phases. You know, if you are not satisfied and the patient is still stable, you can repeat. And then in the literature, people can repeat up to 4 or 5 times. But the maximum I have tried in my series is 2, and it works. And always confirm with ultrasound that that's the meconium is the cause.
I'd like to elaborate on what Dr. Kubota says, and I think it's really important. I think the ideal surgically would be to have a perforation as a very, very rare event that can be, you know, ameliorated by interventions at the bedside in the radiology suite prior to that. And that seems to be achievable in the East. And unless we have a very aggressive approach and deal with meconium obstruction preemptively, we're not going to get there. And even with our aggressive approach, we're still primarily operating on perforation. So it would make me believe that, you know, compared to what Dr. Kubota does in his institution, which is a very aggressive distal kind of enema and emptying approach, you know, we are still failing to prevent perforation in the vast majority of cases.
All right. Well, thank you so much. Those were great talks, and I think that is a good place to end. You know, I think it's admirable to see that you can, you know, with forward progress, work toward that goal of preventing perforation and the poor outcomes associated with it in these infants. So thank you so much to our speakers, to our moderators, to all that submitted questions. And again, you know, this will be recorded. You can look out for it on our Tiny Baby Collaborative website. Thank you.
Thank you very much.